already having a diabetes mellitus, and already patient having a adipopathy, and they are susceptible to develop ketoacidosis. So in both there are involvement of the sick fat cells. So by definition, it is the sick fat. It is a chronic disease of adipose tissue, not only in one day, but it is a long process where there is a pathological abnormal fat distribution. There are various sites where this abnormal fat, sick fat are distributed. They may be healthy also, and there is a hypertrophy of adipocytes. So by definition, it is abnormal pathological fat distribution and adipocyte dysfunction, and that not only result into the obesity or hypertrophy of the adipocyte, but there are other consequences that lead to the abnormal endocrine, inflammatory and metabolic signaling that promote insulin resistance. And because of the insulin resistance, these patients, they may have a hypertension, they may have a diabetes, and that is irrespective of BMI. Many of them, they have a high BMI, but they do not have a sick fat. This is all because the healthy fat is a subcutaneous fat. But once anyone who even they have a normal BMI, but they are fat accumulated in the viscera, then it becomes pathological fat. So these are the various forms of the healthy and unhealthy adipose tissue. In the healthy, there are less number of macrophages. There are M1 or M2 macrophages. They are less number. There is less angiogenesis, and there are less number of mast cells. If histopathologically we see, if M1 and M2 receptor, if they are shift is not towards M2. M1 is the killing macrophages, while M2 is a healing macrophages. So all depends on the macrophages. Apart from that, if it is more and more hypertrophy of adipose tissue, that lead to many cytokines. They may are pro-inflammatory cytokines like leptin, and apart from that, gradually there is a more and more neovascularization, more number of blood vessels comes in the picture, and more and more collagen fibers they are collected. So from healthy to unhealthy, histopathologically if we see if the person is having more fibrosis, in that case the risk of development of various diseases are very high. They are composed of adipocytes, stromal cells and macrophages, which I have pointed out, and healthy one, they may have a good storage in the form of subcutaneous. So adipocytes or fats, they are working as insulation. So they have a good insulin sensitivity, while unhealthy, they may have a insulin resistance. So these are the various sites. There are white, there are brown, and there are mixed type of adipose tissue. So mostly, if it is collected subcutaneously, then it may be healthy. While there are various areas where usually we are not seeing the fat, like in the muscles, like in the liver, they are not the sites where the fat is usually accumulated. So if it is there is accumulation in these sites, that suggests it is a abnormal fat accumulation in the body. So abdominal, gluteal, femoral, all these areas, and this is normal picture of adipocyte where you can see accumulation of lymphocyte, macrophages, and the pre-adipocyte get converted into the adipocytes. So types of subcutaneous fat may be healthy, and there is a good insulin sensitivity and metabolic protective, while visceral fat, they have a pro-inflammatory and there are chances of insulin resistance. Then other sites where we can see the fat, the different types of adipose tissue. Usually in adult, we see the white adipose tissue, while in children, we see brown. When in the white adipose tissue, when the brown comes in white, then it is a bag or bright adipose tissue. So good fat, it has a very good increased amount of adiponectin, while if in bad fat, the adiponectin is less in number. and there is a more and more release of inflammatory cytokines in bad fat, which is usually not seen. And in good fat, there is a healing macrophage, that is M2 macrophage is high in number, while in bad fat, the M1 factor, M1 macrophage comes in picture. So this is the difference between the good fat and as far as in the bad fat, there is a more and more hypoxia, more and more fibrosis as compared to the good fat. And there is always a chronic inflammation in bad fat, and adiponectin, which is responsible for satiety, that is also decreases in bad fat, and leptin, which is also pro-inflammatory cytokines, which is responsible for inflammation, that is also very high in bad fat. So what are the hormones, especially the leptin, which is a pro-inflammatory cytokine, which usually seen in bad fat. Adiponectin is good, which is responsible for insulin, increasing the insulin sensitivity. So these are the hormones. Now what are the etiology? If a person who is taking a high amount of calorie, that is the most important factor for adipocyte hypertrophy. After a long time, there is excessive free fatty acid that usually is spilled from the adipocytes. So after a particular time, when there is a chronic consumption of high amount of calorie which accumulated, so that is the important cause. And for energy consumption, the physical inactivity is also one of the factor which may be responsible for adipopathy. And definitely environment factor and genetic factor is the key factor which is responsible for excessive fat accumulation in the various parts of the body, and that is the adiposopathy. So there is a various sequences seen. Once patient having a chronic excessive calorie intake, so adipocytes get fibrous, and there is a decreased angiogenesis, and the shift of good macrophage to bad macrophages is seen, and apart from that, the various cytokines are released, especially TNF alpha, and then there is a subsequently patient develops systemic insulin resistance, and which is responsible for the diabetes. So in this picture, you can see if a person who is taking a high amount of calorie for a longer period, then the growth of adipose tissue is also increased, and there are impaired adipogenesis in subcutaneous fat as compared to the visceral, and the visceral adiposity is day by day increases. So in such a way, there is a more and more accumulation of fat in the part where usually we are not seeing the fats, like in the liver, like in the fats. So these are the various areas we are not expecting the fat to accumulate, but over a period of many years, there is a more and more accumulation. So how it is initially they may have a hypertrophy, and then subsequently the number also increases, and there is a decreased capillary density, and this patient may have a tissue hypoxia. So inflammation has an important role. There are various recruitment of the macrophages, that may be the one important aspects who develop, and there is a lipotoxicity of even the fat cells. So large number of spillover of the free fatty acid, not only responsible for the diabetes and other part of the body is involved, but the adipocytes itself affect. So there is a vicious circle. There is a hypertrophy which releases or spill over the free fatty acid, and this free fatty acid again damaging the adipocytes. So these are the cytokines, especially the leptin, which is responsible for insulin resistance also, and the adiponectin is also reduces. So what are the conditions which usually we see? The many important conditions, one of them is the metabolic syndrome, which characterized by not only low SDL, high triglyceride, but also they may have a obesity, increased waist circumference. So metabolic syndrome usually see without any, sometimes we could not get any disease also. But what are the diseases which associate with the adipopathy? So important is the diabetic. Apart from that, these patients may have a NFLD, non-alcoholic steatohepatitis, coronary artery disease. So microvascular and macrovascular both are seen in any patient who comes with the adipopathy. So these are the consequences. Very important. One of them is the atherosclerosis. As the age increases, not only the atherosclerosis increases, but they may have a dyslipidemia also. So there is a excessive free fatty acid influx to the liver. There is dry VLDL triglyceride and lowering SDL. So this is responsible for metabolic syndrome also. This is also responsible for insulin resistance. So excessive calorie which lead to the more and more free fatty acid, and this get collected into not only in the pancreas but also in the liver, and which is responsible for gluconeogenesis, increased glycogenolysis, which is responsible for the diabetes. So diabetes is one of the important aspects of adiposopathy, and because it is chronic positive energy balance which lead to the ectopic fat deposition, and subsequently because of the metabolic syndrome they may have a. The obesity is very important part of adiposopathy. There is a because of the adipocyte hypertrophy. So insulin resistance, hyperglycemia, adiposity, and subsequently, if you see over a period of 10 years or 20 years, this pre-diabetic patient may develop into the over-diabetic. Then definitely, if there is a more and more accumulation in the liver, so it may be adiposopathy may lead to the visceral adiposity, and that may lead to the NAFLD or NASH. So therapeutic complication, that is very important since beginning. So calorie restriction is very important. Weight loss is very important. GLP-1 receptor, now we are more or more discussing on the GLP-1 receptor agonist drug, not only for reduction of the weight, but also for the visceral fat, and very important physical activity. SGLT inhibitor for weight reduction. There are many pharmacotherapy which also reduces not only the weight, but also adiposopathy. Now, ketogenesis, I'm just highlighting some of the important aspects where there is a, because of the beta oxidation, the can lead to the insulin resistance. So many of type 2 diabetes patients, especially the obese patient, they are susceptible. Usually, this ketogenesis usually we see in type 1 patient. But once patient become obese, there is a more and more spillover of the free fatty acid in the circulation, and that could be the one reason where the patient may have a beta oxidation. So ketone bodies, acetoacetate, beta hydroxybutyrate acetone, they are more formed in obese patient. I'm not going to because of the. So these patients, when they are obese, they are susceptible. Type 1 definitely. So basically these patients, when there is a beta oxidation, there is a lipolysis, insulin deficiency, relative insulin deficiency, and there is a more and more counter-regulatory hormones. They are responsible for production of the ketone bodies. So counter-regulatory hormones comes in the picture when patient develop ketogenesis. So there is a, because of the insulin deficiency, there is a decreased lipolysis, and because of beta oxidation, all these three ketone bodies, acetoacetate, beta oxybutyrate, and acetone are formed. So when there is a starvation, these are the important fuel, energy fuel. Ketones are energy fuel in starvation. So they are seen use basically brain. When there is a hypoglycemia, the brain needs glucose, but when the glucose not in the picture, then the ketone body play important role in place of glucose. So thyroid hormones, they also responsible for ketone bodies formation. So in the normal, the insulin usually suppresses lipolysis, and ketogenesis usually is not. Every day ketone bodies are formed, but their number are very less. But when there is an insulin deficiency, So counter-regulatory hormones comes in picture, and they are responsible for more and production of ketone bodies. So in the starvation, because of the insulin deficiency, the glucagon, cortisol, catecholamines, they comes in picture. More and more free fatty acid are formed. There is a beta oxidation of this free fatty acid, and which lead to the formation of these ketone bodies. Alcohol, again, in the alcohol, the ratio between NADH and NADH altered, and there is a decreased gluconeogenesis, which lead to decreased production of the glucose, and subsequently, because of the release of this counter-regulatory hormone, glucagon, cortisol, they are responsible for ketogenesis. So metabolic acidosis decay usually seen in obese patient, and this is all because of the not only the hyperinsulinemia but insulin deficiency during stress, and because of the insulin resistance, there is a reduced beta cell reserve, and so there is a very inadequate insulin action. So the counter-regulatory hormone is more in obese patient as compared to the thin build type 2 patient. So target lifestyle medication. Weight loss is very important. We have to target to visceral adiposity. We have to start various medication which can increase insulin sensitivity. So this is a difference between adiposity and ketogenesis. Usually adiposity is a chronic process where the more and more pathological cells are involved, while in ketogenesis there is more and more physiological. And in the primary sites, in adiposity is the adipose tissue, while in the ketogenesis the liver mitochondria. So how we have to deal with the adiposity? So very important, we have to correct the metabolic syndrome, we have to reduce the waist circumference, we target the SDL and triglyceride, we have to target the blood pressure, and we have to target the diabetic. So adiposity is the primary driver of chronic heart diseases, which is corrected by inflammation, visceral fat accumulation, while ketogenesis is the mechanistic antidote for lowering insulin. It is reducing lipotoxicity, and apart from that, the diet, which play a very important role in the management of ketone body formation as well as correction of adiposity. So thank you.
Thank you so much, sir. Over to the chairpersons.
Thank you, Dr. Manoj. I just have one question. In both these conditions, which kind of diet you advise to your patient?
Is like in adiposopathy, where patient is chronically a high amount of fat, because many of them, as Dr. Rajesh Agarwal told, we are not counting the calories. It's not our routine practice. So restriction of calorie is very important for a patient who already obese. And for ketogenesis, the various trial where the intermittent fasting and high protein diet is compared to the high carbohydrate diet. So low carbohydrate diet and high protein diet, that also play important role, like in the ketogenic diet. So these are the two important types of the diets where we can reduce the calorie.
Thank you.
Thank you so much. I request chairpersons to kindly come on the stage to present memento to our speaker. That was Dr. Manoj Indurkar with us. Requesting Dr. Riti Seth to kindly come on stage. Riti ma'am, please come on stage. To chair the next session, I would like to call upon Dr. Ashok Jain and Dr. Ashish Dengra sir to please take their seats as chairpersons. Dr. Ashok Jain and Dr. Ashish Dengra sir. Our speaker, Dr. Himanshu Patil.
Hello.
Over to the chairperson.
So I would like to welcome Dr. Himanshu Patil from the city of oranges. I hope he has bought the oranges for all of us. Himanshu, welcome to Jabalpur,
Thank
city
you so
of
much, sir.
marvels. And he is a very well-known diabetes, thyroid and endocrine specialist. And he is internationally trained endocrinologist and diabetologist with over a decade of clinical, academic and research experience. He has delivered 100 plus invited lectures and contributed to academic publications on thyroid, diabetes and neuroendocrine disorders. And he has n number of fellowships and he has received many awards. Without wasting much time, over to you, Himanshu, to discuss the important topic.
Respected chairpersons, Ashish sir and Jain sir, thank you so much for the wonderful introduction. At the outset, I'd like to thank Bharadwaj sir and Ankit Seth sir for organizing such a wonderful conference and inviting me for delivering this lecture on emerging incretin therapies. At the same time, I would take the opportunity and congratulate Dr. Manoj Indurkar sir for setting a background for the adiposopathy, for making my talk a bit more easier, because the incretins are going to target the obesity and diabesity in general. So,
Caller mic de do sir ko.
अपने आप जा रहा है.
Himanshu, you want caller mic?
Sorry.
Caller mic?
No, sir. I'm comfortable. It's just that there is some technical glitch. So, मेरे को control दे दो, मेरे को pointer वगैरह दे दो, मैं कर लूँगा. नहीं, thank you. Not a problem. ये अपने आप ही change हो रहा है. ये क्या चीज़ है सर? पॉइंटर है, पॉइंटर इसमें आ जाएगा, इसमें आ जाएगा पॉइंटर. ठीक है, अभी नहीं चेंज होगा ना? Okay. So there was some technical glitch. These slides were changing on its own. I wasn't controlling them. So the talk for today is emerging incretin-based therapies. वापस change हो रहा है. Yeah. So these are the objectives for today. We are going to discuss the incretin biology, the next generation incretin therapies, the practical clinical application and patient selection for incretin therapy, the incretin armamentarium, what was the past, what is the present, and what is going to be the future. And then I have a couple of questions for the audience. So what are the incretin hormones? So there are two major mediators. I apologize. There seemed to be some technical glitch, sir.
Can we move to the next topic, if possible, till the technical hitch is there? Who is the next speaker?
Dr. Somnath Raghuvanshi, sir.
Or you can present like this.
Okay, sir.
It is better.
सर वो मेरे को स्पीकर नोट्स दिखने पड़ेंगे ना. Okay, not a problem. So we'll try to do it on this, sir. Not a problem. Yeah, yeah. So कोई नहीं, I'll control it. So this is the incretin hormones. We have two incretin hormones, the glucose-dependent insulinotropic peptide and the glucagon-like peptide 1. So there are two major mediators of incretin effect constituted by the GLP-1 and the glucose-dependent insulinotropic polypeptide. As illustrated, we have the K cells and the L cells that are producing these two incretin hormones. So this is the GLP-1. Yeah. Yeah. नहीं हो रहा. ऐसे ही करता हूँ सर.
Let him come.
ऐसे ही करता हूँ. So we have the GLP-1 receptor analogs, and depending upon the source of origin that has been divided into, मुझे pointer दे दीजिए वहाँ से, वो लगेगा अभी. ये वाला. So depending upon the source of origin, we have the human GLP-1 based therapies and we have the exendin based GLP-1 therapies. Now, just to make a remark over here, the exendin is based on the incretin hormone that is derived from the salivary glands of the Gila monster lizard. So, human GLP-1 analog based therapies, they include the dulaglutide, they include the liraglutide, and the newer ones are the semaglutide. The exendin based therapies are exenatide and lexisinatide. What are the effects of GLP-1 receptor analog? So on the gut, it reduces gastric emptying. On the pancreas, it increases glucagon secretion. It improves beta cell function, and it improves insulin biosynthesis. On the liver, it reduces hepatic glucose production. It increases hepatic insulin sensitivity. It reduces lipogenesis and steatosis. On heart, it reduces inflammation, reduces oxidative stress, and it reduces the RAS. On the kidneys, it causes natriuresis, diuresis, reduces inflammation, oxidative stress, and RAS. On the brain, it reduces body weight, it reduces food intake, and it improves satiety. On the muscle, it improves insulin sensitivity, and on the adipose tissue, it reduces in weight loss. So this is the incretin biology. Now we have the newer incretin based therapies. So the newer ones are the semaglutide, which is available in injectable as well as the oral form. And then we have the tirzepatide, which is a dual GLP-1, and that is tirzepatide. Now why is the world going towards newer therapies? And the reason is because it is more obesity centric, which is required in diabetes management, because nowadays we are not dealing with only diabetes, we are dealing with diabesity. The molecule results in a durable HbA1c reduction with lower incidence of hypoglycemia. It offers cardiorenal protection, and the dose titration and adherence is better because it is also available in weekly formulations. So now we have the patient selection. So which patients are to be chosen? So for this, I have a different type of presentation. So instead of just discussing the indications, I have straight away chosen cases which are my clinic patients, which I would like to share with you. in which these newer GLP-1 therapies have made remarkable improvements in patient management. So this is a patient of, this is a case of a 52-year-old male who has diabetes since 8 years, has a BMI of 34, waist circumference of 110 centimeters, HbA1c of 9.1. The fasting and post meal are 168 and 286 respectively. The comorbidities include hypertension and NAFLD. The current therapy, the patient is taking metformin, sulfonylurea, and basal insulin of 42 units daily. Now, what is the clinical problem in this situation? The patient has gained around 9 kgs in 3 years. Increasing insulin requirement is a major concern. Frequent hunger and poor satiety is another concern. Hypoglycemia, limiting insulin titration. So no wonder we can increase insulin, but then also there is a risk of hypoglycemia. So if you see the guidelines, these are the latest ADA guidelines, and I would like to focus on this part of the guideline, where it says if there is a compelling requirement of weight loss, you should use the GLP-1 receptor analogs. And this, going in alignment with the guidelines, prefer a GLP-1 receptor analog or a dual incretin before insulin. That is what the guidelines mention. Weight loss is prioritized in diabetes management with obesity. RSSDI mentions GLP-1 receptor analogs recommended when obesity is a major driver. So what is the strategy for this patient? Try to discontinue sulfonylurea, initiate semaglutide weekly, slowly go up on the titrations, and gradually down titrate the insulin. So what happens when we did this? There is a remarkable follow-up improvement. So the HbA1c got down from 6.8 to a previous value of 9.1. Weight, it got down to 86 from a previous value of 98. And the insulins, they reduced 18 units. Hypoglycemia, absolutely nil. So what are the advantages of this incretin-based therapy? Central appetite suppression, improved insulin sensitivity, and insulin sparing effect. What is the learning point over here? Escalating insulin in obesity worsens the disease physiology. Treat obesity to treat diabetes. Fortunately, incretins will reverse this cycle, and incretins will also reverse the insulin weight spiral. The next case is of a 60-year-old male having diabetes since last 10 years, had a past history of myocardial infarction for which the patient had undergone angioplasty. HbA1c is 7.4, weight is 31, BMI is 31, eGFR is 72 mils per minute. Current therapy is metformin, statin, and ACE inhibitor. So what is the clinical dilemma? Glycemic control indeed appears to be reasonable because the HbA1c is just 7.4. But there is a persistent residual risk of cardiovascular impending event. So again, when we are in dilemma, we go back to the guidelines. So what do the guidelines say? And I would like to focus on this part of the guidelines. When atherosclerotic cardiovascular disease predominates. And if you see here, you can see a GLP-1 receptor analog. So guideline alignment, in ASCVD, GLP-1 receptor analog with proven CV benefit irrespective of HbA1c. What does RSSDI mention? GLP-1 receptor analog preferred in diabetes with ASCVD. So what happens when we did that? So added semaglutide, the patient lost 7 kgs. And there is no recurrent CV event, and we are monitoring the patient since last 3 years. What is the learning point over here? CV benefit is independent of HbA1c reduction. The next case, we have a 58-year-old female, type 2 diabetes duration is 12 years, eGFR of 38 ml per minute, urinary albumin creatinine ratio is high, HbA1c of 8.2. The current therapy, the patient is taking insulin and ACE inhibitor. What is the clinical challenge? Metformin is restricted because the patient has CKD. Hypoglycemia risk is significant when the patient is on insulin. And the third and the important thing is rising albuminuria. When we are in confusion or in dilemma, go back to the guidelines. So what do the guidelines say? Focus on this part. ASCVD reduction, here you will find somewhere GLP-1 receptor analog. So what does this slide say? SGLT2 with or without GLP-1 receptor analog for CKD progression reduction. So what was the change when you added GLP-1? HbA1c came down, UCR improved, and eGFR slope did stabilize. So what is the learning point? GLP-1 receptor analogs are not nephrotoxic. Next case, of a 50-year-old male, BMI of 39, moderate to severe OSA, obstructive sleep apnea, HbA1c of 7.8, BP of 148/92. What is the clinical challenge? Poor CPAP adherence. I'm sure most of us have OSA patients and they really hesitate to use CPAP. This next is progressive metabolic risk. So I would like to bring it to your notice over here. ADA and EASG recognizes obesity as the primary therapeutic target. Emerging evidence, tirzepatide has been approved for OSA. So Zepbound or Mounjaro, whatever the USA FDA approval is, for the treatment of moderate to severe obstructive sleep apnea in adults with obesity, and they have got this licensing since 20 December 2024. So apnea, hypoapnea spells have reduced, weight loss of around 20%, improved blood pressure and glycemia. This is the outcome of addition of tirzepatide. Now what is the learning point over here? Incretins treat obesity-driven multi-system disease. So we have done with almost most of it. I would just request the seniors, since it was a technical glitch, just kindly let me continue. Thank you so much, sir. So we come to the incretin armamentarium. I have taken this one slide to summarize all the incretins that are available as of now and are going to come in future. So there is semaglutide, there is tirzepatide, there is dulaglutide, there is liraglutide, there is exenatide, there is oral semaglutide, and these are in pipeline. So this is caricema, orforglipron, and retatrutide. These are in pipeline, and if you can see here, this has proven to have superior weight loss in late stage trials. It is still in pipeline. This is phase 3 positive, and this has shown promising data in early phase human trials. Now, with this, I come to the last part of my slide, which is the audience question. So I would recommend participation from the audience. So the first question here is, an obese type 2 diabetic patient with an HbA1c of 9, what should be prioritized? Is it the basal bolus insulin? Is it the sulfonylurea escalation? Is it the GLP-1 analog or dual incretin? Or is it the DPP-4 inhibitor? C. Excellent. Thank you so much, sir. The answer is C. So this becomes an indication. The next question. Why add GLP-1 RA when HbA1c is already near target? Is it for faster HbA1c reduction? Is it for postprandial control only? Is it for cardiovascular risk reduction? Or is it for beta cell preservation only? C. Excellent. So for cardiovascular reduction, this is another indication. Third thing, which statement about GLP-1 in CKD is most appropriate? Contraindicated below eGFR 45, causes acute kidney injury, reduces albuminuria and slows progression, superior to insulin in CKD. C. Excellent. Reduces albuminuria and slows progression. Which patient is best suited for tirzepatide? Lean type 2 diabetes with hypoglycemia, obese type 2 diabetes with insulin resistance, type 1 or gestational? B. Excellent. Obese type 2 diabetes with insulin resistance. And the last question, which comorbidity now has evidence-based benefit for incretins? COPD, OSA, RA or hypothyroidism? OSA. Excellent. So the last part is just one slide where I have spoken all good. I'll speak also something more. So what are the practical aspects? GI intolerance is a known side effect of GLP-1 therapy. Try to titrate it slowly. Gallbladder diseases are reported with rapid weight loss in patients. A couple of my patients, they have taken and escalated the doses on their own and have landed up with cholecystitis. Contraindicated in MEN2 or medullary thyroid carcinomas. And there is a lower risk of hypoglycemia with GLP-1 receptor analog therapy. And with this, I come to the end and the last slide. Thank you so much for your cooperative listening.
Thank you, Himanshu, for a very excellent talk. And pancreatitis, we have to add.
Yes, sir,
in the
definitely.
Contraindications.
Yes, yes, absolutely.
And आपकी गर्लफ्रेंड का नाम सी से शुरू होता था क्या? सारे आंसर सी से थे. Sorry. Any questions from the audience? Kelly sir, Behrani sir.
जी मैम.
Yeah, one question.
जी
Madam,
मैम, please.
mic दीजिए मैडम को. Mic.
Okay, ma'am.
How much is the?
Risk of pancreatic
So,
carcinoma.
excellent, ma'am. I really appreciate your question. So, pancreatic carcinomas, I would take it. So, when we have trials against the molecule, it always, when they report as side effects, they always report it as common and rare. So, I would like to place it on record that pancreatitis, pancreatic complications, they are reported as the rare side effects of the molecules. Unfortunately, at this point of time, we don't have any Indian data saying any specific number which states that this is the number of pancreatic cancer that has been reported on GLP-1, because the number is going to vary according to the population and according to the trials. So unfortunately, at this point of time, I'm not able to quantify, but all I can say that it's a rare complication. I can say that.
Thank you.
Also,
Last
I would
question.
say on record that these pancreatic issues,
This is for the diabetic patient and for obesity and weight reduction. What about these GLP and GIP can be used or we are using in the obesity also, non-diabetic setting?
yes, sir. Recently, there is this higher dose of semaglutide, which we are calling as 2.4 milligram, that has been individually approved for treatment of obesity. So we have that indication. Also, it has been also approved for the use of MASLD. So that is another indication for use of GLP-1 receptor analogs.
We have to jump that dose immediately for that.
Sir, no. It is always you begin with 0.25 when it comes to semaglutide. You always up-titrate it. You titrate it. It is always up-titrate. You begin from the lesser dose and then titrate it monthly. That is what they are saying.
With these drugs, there is a normally
Uh,
hypoglycemia.
sorry to interrupt. We,
Sir, we can
have to
continue
break.
the discussion off stage. I can answer your questions in person.
Thank you so much, Dr. Himanshu Patil.
thank
I
you.
request our chairpersons to kindly come on stage for memento presentation to our speaker. I request Dr. Kanika Seth to kindly accompany. क्योंकि हमारे नेक्स्ट स्पीकर की ट्रेन है जल्दी एंड हमको उनको सुनना भी है, तो मैं फटाफट अपने दूसरे चेयरपर्सन्स को बुलाना चाहूँगी, डॉक्टर अनुपम सहानी सर एंड डॉक्टर PC सेठ सर, टू काइंडली टेक देयर चेयर एज चेयरपर्सन्स. स्पीकर डॉक्टर सोमनाथ रघुवंशी सर. चेयरपर्सन डॉक्टर अनुपम सहानी एंड डॉक्टर PC सेठ. We will not be taking any questions post this session.
Good evening, all of you. Thank you, Dr. B.K. Pradha sir and Dr. Said sir for inviting me here. So, topic allotted to me is the diabetes in the adolescent and the young adult. So, why this is going to be important nowadays? Because the prevalence of diabetes is increasing in the young patients also. Earlier, the diabetes was the disease of the older age, 4th decade or 5th decade, but nowadays we are looking at diabetes in the first decade or in the second decade also. Am I audible? So, we can see the incidence of diabetes is 56 cases per lakh in the adolescent, and also the incidence of diabetes is prevalence is around 2.6% in the age group of less than 20-30 years. So, What is the meaning of adolescent? Adolescent means age group between 13 to 17 year of age, or we can say up to 19. 30 to 19 is adolescent, and what is a young adult is 20 to 30 year of age. So what I am going to discuss about in few slides. So this is the case one, master by apparently well 1 month ago, and over the last 3 weeks his parent noticed that drinking large amount of the water and waking up several times in the night. Despite eating more than usual, he is losing weight. So one day prior, he developed abdominal pain, vomiting, and rapid breathing. So what is your diagnosis? So this is obvious that patient is suffering from type 1 diabetes. So here the birth and developmental history is normal. This is also important, and there is no family history of diabetes in this patient, and build was the thin and usually presented the decay. So diagnosis is certain, he is suffering from type 1 diabetes. So what should we remember in the case of type 1 diabetes? So patient comes to us with the high blood glucose level, elevated level of HbA1c, low C-peptide, and positive autoantibodies, GAD, IAT or ZNT, whatever it is, remain positive. So how to measure the C-peptide in type 1 diabetes? At the time of diagnosis, you will get C-peptide in the range of 1 to 1 nanogram per ml, 1 nanogram per ml, and over the time, due to loss of beta cells, C-peptide goes down and down and down, and by the age of 5 years, we will not able to detect any C-peptide in the type 1 diabetes. So this is important investigation, because all patients are not able to afford the antibody testings. So diagnosis of type 1 diabetes should be considered when young with diabetes have following features, that he having the BMI less than 85th percentile, or age of the patient is less than 10 years, or you can say pre-pubertal age, or absence of risk factor and clinical features of type 2 diabetes like acanthosis and all, and history of decay or come to with cerebral edema or loss of consciousness. So we have to differentiate the type 1 diabetes with the MODY. So here also patient has the BMI less than 80th percentile, but only one difference is that MODY patient don't have decay, diabetic ketoacidosis. So decay present only in the patient of type 1 diabetes, not in the patient of MODY. So this is case 2. 18-year-old female was found to have elevated fasting blood glucose during the pre-college medical examination, and she was asymptomatic totally, no history of polyuria, polydipsia, weight loss or fatigue, and there is no history of diabetic ketoacidosis. So, but he has history of strong family history, young diabetes in three generations. So what is your diagnosis here? So patient is likely suffering from MODY. So diagnosis is MODY. So on examination, they are not obese. There is no signs of metabolic signs are there like acanthosis, blood pressure remain normal, systemic examination remain normal, but they have elevated fasting and post-prandial blood glucose. HbA1c remains slightly elevated between 6.5 to 8. You will not get higher HbA1c value in patient of MODYs, and C-peptide remain normal. So you can differentiate between type 1 diabetes and type 2 with the help of C-peptide, and islets antibody remain negative. So urine ketone remain negative, and genetic testing suggested to differentiate between the MODY. Which kind of MODY patient is suffering, because every MODY has different treatment. So this is case 3. Mr. Y, 31-year-old male, was diagnosed with the diabetes 6 months ago during his evaluation for fatigue. सिर्फ थकावट थी उसको और कुछ भी नहीं था पेशेंट को. He was initially managed as type 2 diabetes with metformin and lifestyle modifications. Despite good compliance to treatment, his glycemic control progressively worsened and he started losing weight. पहले ठीक था, दवाइयों से रिस्पॉन्स आया, अब नहीं आ रहा है. So diagnosis is obvious, but there is no family history of diabetic ketoacidosis and no family history of diabetes. So likely that diagnosis is LADA, latent autoimmune diabetes of young. So they are also lean. There is no acanthosis seen in this patient. Blood pressure remain normal, and systemic examination also remain normal in these patients. But they have low C-peptide. C-peptide remain low or normal in these patients, but they have positive autoantibodies like most commonly GAD65 or IAT antibody remain positive. But urine ketone remain negative in patient of LADA, despite having autoantibody positivity. So I can say C-peptide is better test than GAD antibody when differentiating the type 1 diabetes or LADA, because in type 1 diabetes you will get very low C-peptide or detectable or slightly elevated or normal in the LADA. So this is case 4. This is usual. Mr. So this miss by age is 22-year-old, and she has noticed excessive thirst and increased frequency of urination in last 2 months. He has also reported feeling tired during routine activities, and he has gained 8 kg weight over past 2 years due to sedentary lifestyles and unhealthy eating habits. So there is no history of abdominal pain, vomiting, or suggestive of decay. So what is your diagnosis? So likely diagnosis is type 2 diabetes. Although patient is young, age is 22 year, but patient is suffering from the type 2 diabetes. So here you will get a strong family history of diabetes in the family, and also you will get history of hypertension in the family, and they have history of sedentary lifestyle, sedentary occupations, or high intake of fast foods, sugar, beverages, and minimal physical activity. So suggestive of type 2 diabetes. You will get here in examination they are obese or overweight, have abdominal obesity, acanthosis nigricans. 33% patient have elevated blood pressure. 33% of type 2 diabetes have elevated BP, and you will also get the elevated fasting PP, but C-peptide remain normal or elevated, or in late cases may be low. So, but also have elevated deranged lipid profile. So this is the case 5. This is the, you can differentiate easily among the cases I have told earlier, but this is most important case for me also. She is 8-year-old female patient. She presented to ophthalmology department with bilateral cataract, and on routine examination found to have elevated blood sugar. Fasting was 256, PP was 567, and A1C was 17.8, and urine ketone was negative. So what is your diagnosis? Age is only 8 years. So I was confused how to treat this patient. I have counseled the parents to give insulin, but they denied. They will not. They were not ready for insulin. So I have started on metformin. Review after 7 days, there was no response. Then added glimepiride, but there was no response. So I thought this is not a type 2 diabetes or not a Moody, something else we are dealing with. But surprisingly, I don't know why, she had no symptoms other than cataract. So one thing was certain, that she is having cataract, so disease is likely more than 5 years. She is suffering from since the age of 3 years. So we have done the genetic analysis, and surprisingly she was found to have insulin gene mutation. We have found in this patient. So insulin gene mutation seen in the only in the Moody, in also neonatal diabetes. So we have made the diagnosis of neonatal diabetes, but still I am not certain whether this is neonatal diabetes or not, because in the family there is no history of diabetes. If there is history of family history of diabetes, I get in 3 generations or 2 generations. So this may be a case of Moody, and I have started insulin, and patient responded very well and growing. We have operated for cataract also. So C-peptide is important test. We can differentiate between type 1 diabetes, LADA, Moody, and type 2 diabetes if in the resource limited setting, because type 1 diabetes this rapidly fall to very low level. In LADA this gradually decline over the 1 year period. In Moody preserve remain stable. C-peptide remain in the Moody. I am not going to discuss, because there is difference in the phase 1 and phase 2 insulin secretion in the all the diseases. And type 2 diabetes this remain normal, high initially due to increased secretion due to insulin resistance. So what is the pathophysiology of type 2 diabetes in the young patient that we are dealing nowadays? So decline in the beta cell function. So second phase of insulin induced insulin secretion may be compromised earlier in the pathogenesis of young diabetes and type 2 diabetes. So there are 2 phases, phase 1 and phase 2. So phase 2 is due to immediate release in the presence of glucose. Phase 2 is the delayed synthesis and secretion of insulin. So phase 2 is compromised in the young obese patient with diabetes. So evidence suggests that beta cell loss accelerated in the young diabetes, 30% loss seen in the per year. So they are rapidly require insulin, surprisingly, these patients, young diabetes patients. Some obese patients comes to us, we thought that he is suffering from type 2 diabetes. Many patients I have BMI of 30 or more than that, but surprisingly they are on insulin despite having diagnosis of type 2 diabetes. They are antibody negative but suffering from type 2 diabetes and requiring insulin from the beginning. And as compared to the other patients, they have 7% loss of beta cells per year. So decline in beta cell function in obese patients seen in the 75% decrease in the phase 1 and 50% decrease in the phase 2. In type 2 diabetes, there is decline in general. In normal diabetes, only decline in the phase 2 seen. But here, young diabetes, we see the decline in the first phase of insulin secretion as well as in the second phase of insulin secretion. So, prevalence of obesity among children and adolescent and young, with obesity is much greater than the older adults in the recent studies. So obese adults and have chronically increased level of circulatory free fatty acids, which decrease insulin sensitivity and contribute to increase ROS and impair the insulin secretions. Chronic low-grade inflammation is important because increase in the TNF alpha, interleukin, adipokines seen in the patient of young diabetes. So they are remain in the state of chronic inflammation. So they are responsible for loss of beta cells. So obesity is clearly a driver for upsurge of type 2 diabetes in young, and change in the lifestyle account for much of the increased prevalence of obesity and diabetes in pre and early adult life. So we can see earlier the incidence of diabetes was less but the mortality was high, but nowadays incidence of diabetes, particularly type 2 diabetes, increasing day by day in the young patients, but mortality is decreasing due to better health facilities available nowadays. So what is the memory, metabolic memory? If you are lean in the childhood but obese in the adulthood, so you are at the higher risk of developing the diabetes and cardiac disease as well as hypertension. If you are having you are obese in the childhood and obese in the adulthood, so risk of developing diabetes is moderate, but you are having average build throughout in the childhood as well as adulthood, so risk of diabetes is less. So pattern of weight gain is also important, how you gain the weight. So increases the non-communicable disease like diabetes, hypertension and heart disease, etc. So what are the recommendations when patients comes to you, young patients come to you with the obesity? You should always screen for diabetes. If you get elevated level of fasting plasma glucose or HbA1c between 5 to 7, always do an OGTT testing to look for the elevated post-prandial blood glucose level. And if you target the HbA1c less than 6.5, and also screen for the cardiorenal risk if even the patient is young. So when the target blood pressure, there is a mistake in, so blood pressure target should be less than 130 by 80, and you have to advise the exercise 300 minutes per week in the young kids or patient with young diabetes. And beta cell decline is more rapid and more frequent, and early intervention and intensification. So you have to frequently change the medication, intensify the treatment to prevent the beta cell loss, and also focus on the weight loss therapy whenever possible. So patients comes to you with the diabetes, what to do? You have to treat with the metformin if they diagnosis type 2 diabetes, along with basal insulin, along with the liraglutide and dulaglutide and other treatment also there. So if HbA1c is less than 8.5, you treat with the metformin only along with the other measures. HbA1c more than 8.5, you have to start with the basal insulin plus metformin. If HbA1c is more than that and ketone is positive, you have to start with the basal bolus insulin and review after 4 weeks the patient and check for the ketones and extra, etc. If there is ketone is negative and patient is doing well, you have to reduce the dose or switch to OHA. So these are the recent guidelines in the young with diabetes. So what are the newer therapy available? So actually I have next 10 minutes, so I am running fast. So liraglutide is approved in the age group more than 10 years for treatment of obesity as well as for treatment of diabetes. So in the kids with more than 10 years, we can use the liraglutide. So we can start with the usual dose of 0.6 milligram once a day and uptitrate up to, you can say 3 milligrams we can give in the liraglutide. Exendine is also approved in the patient with young diabetes, and dulaglutide also approved. So we can use liraglutide as well as dulaglutide in patient with diabetes, young patient, those who are more than 10 years of age. Below less than 10 years, insulin is the choice, I think. So what OHA we can give in patient? If age is more than 10 years, we can use empagliflozin in patient. We can use the combination of empagliflozin with metformin, and also we can use the dapagliflozin. So these are the recommended medication for young patient coming to with type 2 diabetes. So every young patient is not suffering from type 1 diabetes. Remember, nowadays prevalence of type 2 diabetes is increasing. Prevalence of type 1 diabetes is 5%, while prevalence of type 2 diabetes in young is 2.6% in India. So we are getting many cases of type 2 diabetes in young patients. So remember and treat accordingly. So thank you very much for patient listening.
Thank you so much, sir. We understand you have a train. I request our chairpersons and Dr. Deepak Behrani, sir, to kindly come on stage to present memento to our speaker. A huge round of applause. Clappings, please. Thank you. I request Dr. Behrani sir to present memento to our chairpersons. सर से आप ले लीजिए वो ट्रे लीजिए सर से Thank you so much. Moving on to our next session, speaker Dr. Himanshu Shukla, our chairpersons Dr. Rajendra Bisen and Dr. Sushil Tripathi. I would like to call upon Dr. Rajendra Bisen and Dr. Sushil Tripathi to chair for Dr. Himanshu Shukla.
Very good evening to everyone. At the onset, I would like to thank Dr. Bharadwaj sir and Dr. Ankit Seth sir for giving me the opportunity to present myself in this podium. My topic is basically diabetic retinopathy and evaluation and management. So basically, if you see, diabetic retinopathy is a type of a microvascular complication of chronic uncontrolled blood sugar, that is hyperglycemia. The risk factor, systemic ones for developing and worsening of diabetic retinopathy is hyperglycemia, that is uncontrolled blood sugar with a raised HbA1c level, duration of diabetes, associated hypertension, diabetic nephropathy, dyslipidemia, anemia, obesity with or without metabolic syndrome, smoking, and nowadays puberty and hormonal changes have also been considered to be a cause for diabetic retinopathy development. Now if you see a normal retina, this is a normal retina, how it look like. The central area, what we see, it's called as the macula, and the area that is, this is the area where actually the light falls and we are able to see. The surrounding area is called as the peripheral retina, and when this is involved, we call, and the central area of the macula is called as fovea. When the macula is involved, we call it diabetic maculopathy, and when the peripheral retina is involved, we call it as a peripheral diabetic retinopathy, or more commonly, the diabetic retinopathy. Now, if you see, diabetic maculopathy is less concerning for us, and diabetic retinopathy is more concerning for us, especially with regards to the presentation that I'm doing with the audience. Reason being, if a patient has diabetic maculopathy, he will have early visual symptoms and he will seek help even without being in the knowledge of his diabetologist. On the contrary, a patient with diabetic retinopathy will have very late visual symptoms and he seeks help in very advanced stage, and therefore we require to screen these patients. Now, if we want to see the effect of diabetes on retina, we have seen there are around two broad types, that is diabetic maculopathy and diabetic retinopathy. Diabetic maculopathy is basically an exudative type of lesion or ischemic type of lesion. That means the vessels ooze out something and there is exudation in the retina, or the vessels are blocked, capillaries are blocked, and we have ischemia. The exudation can be acute or chronic. Acute exudations usually leads to cystic spaces inside the retina, or there is a diffuse swelling or a spongy swelling of the retina. This, if it is associated with hard exudates or lipid exudation, it usually happens in chronic cases. Now, the diabetic retinopathy is usually ischemic. There is exudation, but mostly the problem is ischemia. And this ischemia, if it is sufficient enough, if it is not causing any complication, it is called as the non-proliferative diabetic retinopathy. But if the ischemia is sufficient enough and it causes complication, we basically categorize it as proliferative diabetic retinopathy. The non-proliferative is mild, moderate, severe, and very severe in the classification type, and the PDR is basically early, high risk, and advanced. Now, what happens in proliferative diabetic retinopathy? The major point of differentiation between non-proliferative and proliferative is neovascularization of the retina, which is basically in the form of outer part neovascularization, that is NVE, neovascularization elsewhere, or neovascularization at the disc. What happens if this neovascularization is not taken care of? There is vitreous hemorrhage from these new vessels, that is hemorrhage in front of the retina. There is retinal detachment due to traction, and there is formation of secondary glaucoma because of neovascularization in the anterior part. Now, if you want to manage diabetic maculopathy and the non-proliferative diabetic retinopathy, these can be managed by medication, systemic control, intravitreal injections, lasers, and if required in some of the cases, vitrectomy. But to manage these complications, you require intravitreal injections, vitrectomy surgeries, and the laser treatment. Now, just to see, this is how a diabetic maculopathy looks like. We have seen the normal retina, the center area is involved. Now, the first culprit that we see are microaneurysm. Basically, they are dilatations of the small capillaries, and there is diffuse leak from the capillaries, and these leads to exudation, initially in the form of fluid and later in the form of lipid crystals, which we call as hard exudates. Now we come to the non-proliferative diabetic retinopathy. Non-proliferative diabetic retinopathy is considered to be the non-serious type. Here you have microaneurysms in the periphery, and you have intraretinal hemorrhages along with other findings that we are not going to discuss right now, but these are benign changes. On the other hand, if a patient has a proliferative diabetic retinopathy, he can present you only with this picture. Now, this appears to be a normal picture, but if we see, this is a deceptive PDR because we have a neovascularization elsewhere, which is very difficult to catch. But if you don't catch it and treat it, the patient will develop areas of increased neovascularization and hemorrhage in front of retina called as the vitreous hemorrhage. Now to diagnose, most of the diagnosis is basically clinical, but we require certain diagnostic tests to find out what's the stage of diabetic retinopathy and how's the status of diabetic maculopathy. These tests are optical coherence tomography, fundus fluorescein angiography, and B-scan. Optical coherence tomography is basically a non-invasive technique, and it gives the real-time biomechanical structure of the retina. It is used mainly for the patient with diabetic maculopathy and to see the response of our treatment. Fundus fluorescein angiography basically requires use of fluorescein dye. It is useful to finding out the peripheral retinopathy status. It is especially useful to find out the ischemic status of the macula and peripheral retina. The ultrasound B scan, its use is now limited to the areas where you cannot see the retina due to media opacity, which can happen because of vitreous hemorrhage or cataract. So, if we see an normal retina, which we have seen earlier, this is the central retina. And if we can cut through a section of it in a live patient without damaging the eye, this is what OCT does. So basically, if you see a normal OCT, the normal OCT is a scan like this, and it goes to the central part. You can see a normal foveal dip, and there are basically 10 layers of retina packed one over the other. This is how a normal OCT should look. But in cases of diabetic macular edema, what happens is there is swelling in the central area because of leak of fluid from the capillaries, and they accumulate within the layers of the retina, thus leading to cystic space formation. And when this is chronicalized, there's hard exudates which appear as hyperreflective dots on the OCT scan. Now, OCT is also helpful to find out how a treatment works. So if you see, this is a patient in which on the right hand side you can see the cystic spaces in which the injection was given, intravitreal injection, and the patient responded very well. So the patient responded also with vision, and also we could see there was reduction in the fluid. Now coming to the second test, this is angiography, and if you see an angiography, this is a normal person's retina, how it should look, and this is the same patient's angiography. So we put a dye in the arm, the dye reaches the eye within few seconds, and we start taking photographs. The dye is only able to go through the choroidal vessels, but they don't come out to the retinal vessels, and when we take the photographs, we are able to find out from which area the retinal vasculature is weak. So this is how a normal angiography is, and this is how it's an angiography of a diabetic patient. So what we see over here is an ischemic area in the periphery where the vessels, the capillary area has been disturbed, and you can see this neovascularization which appear like bulb-like lesion, and their exudation progressively increases. Now coming to the management of diabetic retinopathy, irrespective of what we say, the best management is systemic control. Blood sugar control, trying to keep the HbA1c values to a lower side, somewhere around 6. Blood pressure control, management of dyslipidemia, nephropathy and anemia, and lifestyle management. This, along with if the patient develops some complication, intravitreal injections are the most commonly used drug to treat patient. They are mainly used for diabetic macular edema. Their role is visual recovery in these cases. Early PDR, they basically clear the hemorrhage so that we can do the definitive treatment in these cases, which is laser, and pre-vitrectomy before going for the surgery, so that during the surgery we don't have much of the bleeding. After that, basically there are two groups of intravitreal injections. One is anti-VEGFs, the drugs being bevacizumab, ranibizumab, aflibercept, brolucizumab, and faricimab. And sometimes we also use steroids, basically the dexamethasone implants, triamcinolone, and fluoroquinolones. After the gold standard still for treating diabetic retinopathy, the peripheral diabetic retinopathy, is retinal laser photocoagulation. Basically, it is used to prevent complication before in the proliferative diabetic retinopathy stage, and it also stabilizes the diabetic macular edema. Vitrectomy surgeries are basically used to manage the complication of proliferative diabetic retinopathy, and with new generation of microincision technique, we now have better results and earlier rehabilitation in these patients. Now, one of the examples, you can see that this is a patient who had who was given an intravitreal injection of for a DME, and he responded very well after the injection, and the vision also improved. Now, coming to proliferative diabetic retinopathy, as I told you, still the laser is the gold standard, and this is the photograph that I showed you earlier where the patient had a neovascularization. And we went ahead and did 2 sittings of laser, and when complete laser was done, you can see that the neovascularization has disappeared, and now patient has a stable retina, although still after that he requires a good glycemic control to maintain this status. Then this one of the patient, we have seen the patient had a neovascularization developing, and this is, we have caught the patient early, so all we required to do was do an extensive laser at the area where we can find out loss of capillary network, and we see a post laser recovery. But even after doing all those things, there are chances that the patient might develop complication in the form of vitreous hemorrhage or traction in the retina, and in such cases, we perform the vitrectomy surgery. Now, with the help of these new age vitrectomy procedures, you don't have to make any cut or incision in the eye. What you need to do is, these what you see, they may appear big, but this is basically a 27 gauge trocar cannula system. An instrument is so small that you don't have to make any cut in the eye. You go inside, and now the instrumentations are so better that you can just treat the area even in front of the retina without damaging the retina. And they have these cutters which are high-speed instruments which remove only the damaging tissue and don't do anything to the normal retina, thus protecting maximum retina that you could get. And the best part of the story is you don't have to put any sutures. You just move the plug out, and this is that one day the retina and anterior segment appears good, and within 1 week the patient can go off, or 10 days maximum, to his job. So thus, in summary, diabetic retinopathy is a vision-threatening condition which develops in eye of a patient with chronic diabetes. Peripheral retina is a silent killer of the vision and requires early and regular screening of patients, especially those with longer duration and oblique or an uncontrolled retinopathy. Latest and advanced treatment procedure ensures visual recovery and preservation even in relatively advanced cases of diabetic retinopathy. And if managed well on time, visual loss due to diabetic retinopathy can be prevented. Thank you so much.
Over to the chairperson.
Very nicely sum up by Dr. Himanshu. One thing I would like to highlight, the screening for diabetic retinopathy. That is very important since it's a forum of diabetologists, and we are here. So this thing is very important, that how, because of the looking at the burden of the diabetic retinopathy at our country, it is not possible, and sometimes all the diabetic patients, they don't come to the ophthalmologist. So the RSDI and the Vitreoretinal Society of India having a collaborative efforts for that, and they are having multiple seminars and this thing. So the screening part should be have a opportunistic screening. So in that, involvement of the diabetologists are more important, and they got the opportunity that patient comes to every diabetologist and physician, so they should have screening for diabetic retinopathy, and for that they are doing their work also. They are having fundus cameras and AI incorporated fundus cameras also, and this thing should be more highlighted and more work on
The
this.
only thing is, now we are going to come with this AI system. We are expecting by 2028 you will have cameras in your OPDs which are not going to be very costly because they are made in India. They will have this, what we call as a traffic light signal method. Traffic light signal means the patient comes, you just take a photograph of the patient, and the camera, the AI will automatically tell you it's whether green, yellow or red. Green means let the patient go, nothing will happen, keep him on a regular follow-up. Yellow means it's better to keep on a low follow-up or better to send it to a retina specialist. And finally, if it is red, then definitely he requires an urgent treatment with a retina specialist. Unfortunately, the problem is initially what we tried to get the normal photograph and let the AI read it. But what we eventually found out that it is very difficult to do so. So what the new dictum is coming is, we take the image that we showed you, the similar image is taken by the AI, and AI is asked to create its own image. And when the AI creates its own image, seeing that image, the consistency with finding out neovascularization, that's the main culprit. That is what we want. We are not much interested in diabetic maculopathy, because if a patient has a problem in the center, he will come to a eye specialist. But in a retinopathy, the patient might be coming with the first complication of a detachment, and it's a big complication. So if you want to see this patient early, and if you have a camera which can tell you, no, this vessel is not good, send it to a doctor. So this is what we are having, and what the results we have recently in the Kenya study, we found out that patients, when the AI was taught in this manner, that it was asked to create an own vascular diagram, seeing the fundus photograph of the patient, it created a very good algorithm and found out very early that the patient had a proliferative disease.
Thank you.
Thank you so much, sir. Thank you, Dr. Himanshu Shukla, for this lucid presentation. I request our chairpersons to join on stage. I also request Dr. Yatish Jain, sir, to kindly come on stage for memento presentation to our chairpersons. Please, sir. A huge round of applause. Indeed, very well explained. For the next presentation, I would like to call upon chairpersons Dr. Manoj Indulkar sir and Dr. Rajesh Kevat sir to please take their seats as chairpersons. Dr. Manoj Indulkar and Dr. Rajesh Kevat. Our speaker, I would like to invite Dr. V.K. Bharadwaj sir. Over to the chairperson. Kindly
Now it's
introduce.
pleasure to invite Professor V.K. Bhardwaj, sir, DM endocrinologist. He is Medical Director, Hormone Clinic, Right Town, Jabalpur, and former Head Department of Pediatrics, NSB Medical College, Jabalpur. Dr. B.C. Roy, Oration Award, IMA MP State 2012, and Charak Award, IMA MP State 2016.
Thank you, sir, for kind words of introduction. At the outset, I would like to thank all the delegates for being present till late in the evening. I am thankful to Vishud Seva Samiti for giving us an opportunity to organize a meeting on relevant topics related to management of diabetes in the current scenario. My presentation is related to brain and glucose. If you look at brain metabolism, glucose is the main source of its energy. It accounts for 2% of body weight and consumes 20% of body's energy in resting stage. It has no storage of glycogen, meets entirely the requirement from circulating blood. Supply of glucose can be increased by increasing the blood flow, which is relevant in neonates and infants with open skull sutures, not relevant for adults. CSF glucose concentration is less than that in plasma. In euglycemic status, in euglycemic clamp technique, the CSF glucose is 1.5 to 3, that is 27 to 36 milligram per deciliter at a plasma glucose level of 5, that is 90 milligram per deciliter. At plasma glucose of 20 millimoles, that is 360. The CSF glucose is only 5, that is 90. So glucose concentration in plasma tends to be, in CSF tends to be less than what it is in the brain. So brain is protected from glucotoxicity. In normal weight adult humans, body's stores of nutrients amount to approximately 140,000 calories as fat and 24,000 calories as protein, but only 800 calories as glucose, including the glycogen from muscles and circulating glucose. So the total storage of carbohydrate is 800 kilocalories, 24,000 kilocalories from protein, and 1,40,000 kilocalories from fat. If we take 2,000 kilocalorie diet per day, 40% carb and 40% fat, 20% protein, daily intake of fat and protein amounts for 0.57% and 1.6% of body stores, whereas daily intake of carbohydrate would be comparable to total body stores of carbohydrate. So total carbohydrate intake is about 800 kilocalories, and the total store of carbohydrate in the body is 800 kilocalories. So the storage of carbohydrate in the body is very small. A CSF level as low as half a millimole has been recorded in situation of severe hypo, that is plasma glucose of 18 to 27 milligram, 36 to 54 milligram. A plasma glucose of as little as 9 has been documented. Nature has created mechanism to ensure regular supply of glucose to brain, and this elaborate system of glucose sensors in peripheral and central nervous system and effector mechanism to prevent glucose from falling low during acute stage. And glucose sensitivity has been detected in numerous central and peripheral neurons. Peripheral non-neural glucose sensing cells include pancreatic alpha and beta cells, glucagon-like 1 secreting enteroendocrine cells, and the intestinal mucosa. Taste cells in the oral cavity also sense glucose. In addition, there is a glucose sensing capability which impact on central control of counter-regulatory responses in portal mesenteric vein. So we have a series of sensors for glucose from detecting fall in glucose early so that a corrective action can be taken. The hypoglycemia related input from periphery are relayed to the hypothalamus and hindbrain. The signals are integrated and an appropriate response is initiated to maintain plasma glucose in the desired range. There is increase in gastric motility to enhance digestion and absorption of nutrients from GI tract. The counter-regulation begins at plasma glucose falls below 70 in the form of catecholamine release as immediate intervention and growth hormone and cortisol release as long-term strategy. Initial counter-regulation is by catecholamine, which causes palpitation, tremors, irritability, cold extremities, and cold perspiration. With progressive decline, as the plasma glucose approaches 50, there is increased likelihood of development of neuroglucopenic symptoms like hunger, irritability, confused state, and progressive decline may lead to seizures in previously known persons with seizure disorder or de novo seizures. Altered level of consciousness can occur at a level anything below 50 milligram per deciliter. Physiological defenses normally include decrements in pancreatic beta cell insulin secretion as the glucose level declines below the physiological level of 70 to 70 milligram per deciliter. The glycemic threshold for decreased insulin secretion is approximately 18 milligram per deciliter. At a level of 70, it is shut off completely. Increments in beta cell glucagon and adrenomedullary epinephrine secretion, among other neuroendocrine responses, normally occurs at a glucose level of around 50 milligram, around 68 milligram per deciliter. If these defenses fail to abort the hypoglycemic episode, lower glucose levels trigger a more intense sympathoadrenal response that causes more autonomic symptoms. Really profound hypoglycemia causes brain death that is not result of fuel deprivation per se. This is a new concept. Hypoglycemia does not cause brain death. In the cell cultures in vitro rodent studies of glucose deprivation and marked hypoglycemia, there is evidence that hypoglycemic brain neuronal death is in fact increased by non-neuronal NADPH oxidase activation during glucose reperfusion. This finding suggests that at least in the setting of profound hypoglycemia, therapeutic hyperglycemia should be avoided. So if patient has severe hypoglycemia and you give intravenous glucose, it can lead to activation of NADPH oxidase and can be detrimental in the form of causing further neuronal damage. So like reperfusion injury in myocardium in ischemic state. This neuronal death is induced by activation of NADPH activation with induction of hyperglycemia in a severely hypoglycemic individual. There is a condition known as hypoglycemia-associated autonomic failure. In the event of severe hypoglycemia or after repeated hypoglycemic episodes, the responsiveness of adrenergic counter-regulation may be blunted, and it leads to a lack of warning symptoms and greater likelihood of severe and prolonged low sugar, the condition known as hypoglycemia unawareness. Long duration of diabetes and good control paradoxically may increase the risk of low sugar with minimum warning symptoms. So if patient has good control, it may predispose him or her to develop hypoglycemia-associated autonomic failure and hypoglycemia unawareness. Both the cognitive awareness of hypo and the normally elicited counter-regulatory responses are diminished or absent, greatly increase the risk of death or injury from fall or frequent hypoglycemic episodes. The recurrence risk is reduced by inducing slight decontrol for about a week. So hypoglycemia begets hypoglycemia through hypoglycemia-associated autonomic failure, and the treatment is controlled increase in the glycemic levels so as to prevent occurrence of repeated episodes of low sugar. Thank you.
Thank you, sir, for nice deliberation. Like in patient of acute myocardial infarction, there is a reperfusion injury to the myocardium. Likewise, if we are correcting hypoglycemia very fast, what sir said, there may be a chances of reperfusion injury to the brain cell. Initially, we thought the persistent hypoglycemia lead to the neuronal damage, and that lead to death of a patient in hypoglycemia, especially in elderly. So this is a new thing which comes up with such deliberation. So we have to correct very slowly. Sir, any study which suggests ki how much glucose we have to give? Because in our wards, every day one patient usually comes in as our PG to start 50%, 50 ml, 50% glucose immediately. So is any study where we can give a very slow infusion of glucose rather than rapid correction? Because already since many years we taught ki once patient develops severe
patient
hypoglycemia.
Is conscious, it is rule of 20. Give 20 gram of glucose, measure plasma glucose after 20 minutes. If it is below 70, repeat 20 gram of glucose. Repeat this process until the plasma glucose rises above 80. After 20 minutes of last supply of 20 grams of glucose. At that point, give something to eat, something which gets digested slowly, like a chapati or sweet corn or biscuits or any cereal-based product. If time for next meal is due within half an hour, give the complete meal without giving the dose of insulin before that particular meal, and adjust the insulin before the next meal, the rapid acting dose of insulin before the next meal. If patient is unconscious, give 25 milliliter of 25% dextrose as a bolus for 10 minutes, and start 10% glucose at the rate of 50 to 100 milliliter per hour. Keep plasma glucose between 100 to 200, and if patient recovers, regains consciousness and is able to eat and has not suffered any injury because of fall or because of seizure activity, he can start his meal with reduced dose of rapid-acting insulin. And if it has occurred at night, then reducing the dose of nighttime or basal insulin given at nighttime or any time of the day. If it is Stacibau Tuzio, then you reduce the dose of insulin basal, and if it has occurred prandially, postprandially, then you reduce the dose of rapid acting insulin by 10 to 20%.
Sir, after giving a rapid infusion, usually what we see in our medical ICU, the blood glucose rapidly rises to 300. But your message, we have to correct very slowly, does not allow to cross more than 200.
Does not, it should not remain above 200 for a substantial length of time. So you give 25% bolus, start 10% glucose at the rate of 50 ml per hour, can increase it up to 100 ml per hour till the plasma glucose stabilizes.
Sir, is this the same for diabetic patient also? A patient is diabetic and he develops hypoglycemia, and we correct this hypoglycemia. So the time duration of giving this glucose is same or different?
No, for any hypoglycemia, be it in a diabetic individual due to exogenous insulinotropic drugs, insulin secretocoque drugs, or insulin per se, if that causes hypoglycemia, or if it is because of endogenous hyperinsulinemia, the treatment target is same, to keep plasma glucose above 80, preferably between 100 to 200. Means the administration of endogenous hyperglycemia, except because of inborn error of metabolism, is usually because of hyperinsulinemic state, or it may be because of chronic